According to the previous report, selected patients with locally advanced pancreatic cancer may become candidates for curative resection following neoadjuvant therapy. However, the optimal management for LAPC remains unclear. This is the NCCN guideline for LAPC treatment. After the various kinds of first-line therapy, a patient with good performance status and no disease progression are the candidate for the resection as a second-line therapy. These are the recent reports about international survey of the management of locally advanced pancreatic cancer. They conducted electronic international survey by email regarding the current practice of LAPC. 153 surgeons in high-volume center from 4 continents are included. As the result of the survey, 33 surgeons offer a minimally invasive approach, and 50% surgeons offer arterial resection in select patients, and 72 surgeons always recommend neoadjuvant chemo, and 65 prefer FOLFIRINOX as a first-line therapy, and 43% prefer more than 4 months neoadjuvant chemo. However, there is substantial variation in management of preferences. This is the recent published data from MGH in Annals of Surgery. 110 patients, resected patients were included. Half of them are LAPC by AHPBA criteria. They performed 100% FOLFIRINOX and 90% received radiation. And our resection rate was 81%, and MST was 37 point month. And the similar paper from the Johns Hopkins, they reported 84 resected cases. This is 100% LAPC by NCCN criteria. 63% received FOLFIRINOX, and 96% had a radiation. They conducted arterial resection in 27%, which is DP curve, and MST was 35.5 months. This is also published in Annals of Surgery from Sweden this year. 52 resected patients. 85% are LAPC, and 35% received FOLFIRINOX, and 35 patients received GEMS-based chemo, and 25% received radiation. And as a result, overall median survival was 31 in BR patient and 21 in LAPC patients. And at last, this is also similar report published this year in Annals of Surgery from Mayo Clinic. 194 resected patients are included, and 70% of them are borderline resectable, which is defined by the intergroup trial criteria. And 85% received FOLFIRINOX, and 75% of them had more than 6 cycle chemotherapy. And our resection rate was 94%, and MST was 58.8 months. This is our previous data, 70 resected patients. This is include all the data. So 2002 to 2008, we conducted upfront surgery, and 2009 to 2015, we used gemcitabine plus S1 neoadjuvant chemotherapy. 100% of them were BRA by JPS criteria, and we did GS chemotherapy, and 38% received arterial resection. And our resection rate was 55%. Overall survival time was 19.6 months, but in the patient with neoadjuvant GS therapy, the median survival time was 27.2 months. So our basic strategy for locally advanced PDAC, from 2015 to present, we are doing a clinical trial of neoadjuvant gas chemotherapy, which include gemcitabine, nab-paclitaxel, and S1. This is our phase 1 study data, and patient with borderline resectable and unresectable LAPC were included in this trial, and we have already determined the recommendation dose of the gemcitabine and nab-paclitaxel and S1. And now we are doing a multi-center phase 2 trial, and we have already finished the patient recruitment. 60 patients are finished, so we will see the result in a few years. So in summary, recent retrospective study demonstrated median OS in well-selected LAPC patient receiving multimodality management ranges 22 to 59 months, and margin negative resection rate was up to 94%. So as a surgical management of LAPC, margin negative resection is the key for the better prognosis, and arterial resection might be one option for margin negative resection for LAPC. So next, I'd like to talk about our experience about pancreatectomy with arterial resection for LAPC. We conducted 21 patients with hepatic artery resection and 23 patients with DP CAR and 5 patients with SMA resection. In terms of hepatic artery resection, this is a representative case, CT before treatment. The tumor involved the bifurcation of the GDA, and after the GS treatment, the size of the tumor a little bit decreased, but still there's an involvement of the tumor. So we conducted PPPD with hepatic arterial resection and end-to-end anastomosis of CHA and PHA, and end-to-end SMV and PV were conducted. This is the patient characteristics of hepatic arterial resection in our institutions. 62% had a gem-based resume, including 6 patients with GS and 5 patients with gem, nab-paclitaxel, and S1. 57% had a resection of CHA, and 71% had arterial reconstruction. 6 patients with variant hepatic artery didn't have arterial reconstruction. And 95% received concomitant reconstruction of PV. And this is a short-term outcomes. 90% has a postoperative complication, including 1 grade C fistula and 2 biliary fistula and 1 hepatic infraction. There's no hospital deaths, and 90% had adjuvant chemotherapy. And this is overall survival after in this patient. MST was 30.2 months. In terms of DP curve, this is short-term outcomes. 13 patients received GS chemo, and 11 patients had a gas resume, and 30% had a post-operative complication, including 6 patients with BC fistula and 1 liver abscess. We had 1 hospital death, and Our resection rate was 74%. And overall survival curve revealed that MST is 27.5 months. In terms of PD with SMA resection, this is the schema of our procedure. In this 5 patients, all patients received GS neoadjuvant chemotherapy, and we conducted direct anastomosis between SMA and aorta. This is the outcomes. Complication, we had 1 grade C POPF, grade C, and 1 biliary fistula, and there's no hospital death, but overall survival time was only 17 months. So PD SMA resection following neoadjuvant GS might be not acceptable. This is a systemic review regarding the SMA resection. 70 patients undergoing pancreatectomy with SMA resection were included, and morbidity ranges from 39 to 91%. There were 5 operative deaths in the 25 patients recorded. Then overall survival time was only 11 months, so they concluded there is no evidence to support SMA resection during pancreatectomy. In conclusion, the optimal management for LAPC remains unclear, and as a surgical management for LAPC, margin negative resection is the key for the better prognosis. And arterial resection might be a potential powerful tool and feasible approach for well-selected patients, especially for the hepatic arterial resection or celiac axis resection. Thank you for your attention.
Yeah, thank you for a good talk. One question. Which criteria do you use for defining the R0 margin? It's HCC criteria or Leeds criteria?
We usually use 0 millimeter criteria.
Which criteria? Leeds or 1 millimeter?
0 millimeter.
Just the margin-free criteria. So
yes.
you clarify the R0
0 millimeter
definition.
criteria.
So, yeah, it's very important.
Short question, okay? Thank you for that good speech. I'd like to ask about GEM, paclitaxel, and S1. Did you see any kind of advantage comparing to the GEM and paclitaxel? Or the GEM, paclitaxel, S1 treatment? Did you see any advantage comparing to the GEM plus paclitaxel without S1?
It's a very important question, but of course we don't have a data. But in Japan, for the adjuvant therapy, S1 is a key drug. So that's why we involved the S1 in the neoadjuvant regimen.
Thank you, Professor. I'm from Nanjing. I have very interesting about the SMA resection in your study. There are 5 cases. They survive from 13 to 39 months.
Yes.
So in these 5 cases, after SMA resection and reconstruction, the quality life, I mean the long-time complication of the SMA resection, in these 5 cases, they have very, very serious this kind of complication, like abdominal pain. Did they have this kind of complication?
You mean the diarrhea or something like that?
The ischemia of small bowel.
Ischemia. We don't. After the SMA resection and reconstruction, we usually see the CT regularly, but there's no flow disturbance. So I think it's not a problem of the blood flow, but to resect the SMA plexus is one of the most important key for the adjuvant chemotherapy. So That's
It
Yeah.
means the life quality is still better in these 5 cases.
sorry.
The quality life, the life quality of these 5 cases.
Quality of life, nutritional
Quality,
status, time
it-
in and out of the hospital.
Only 5 cases, so it depends on the patient. But some patient had no drug for the diarrhea. So, but some patient had a very severe diarrhea. So it depends on the cases.
Thank you.
Yeah, maybe regarding the ischemia of the intestine, he usually anastomosis the aorta and SMA directly. Maybe the blood flow is very, very abundant compared to the splenic artery and SMA anastomosis. Maybe no ischemia.
Yes. Thank you.
Okay, thank you very much.